Thank you very much, and thank you again to James, who suggested I talk on this. I think he had a fixed idea about how I was going to answer this question, but I think I'm also going to give a slightly controversial opinion by the end. So who should operate on emergency laparotomies? As I say, this is a very controversial topic, and I hope to put forward some of the evidence that may help us make this decision. But it was as early as 1957 with the eminent Cuthbert Dukes, who said, I should not choose the operation, but I should choose the surgeon, and I should choose him with very great care. And I think that's the point. It has to be the right person doing the right operation at the right time. As late as the 1990s, certainly during my training, the general surgeon did everything. And I certainly worked for surgeons who did a bit of vascular. They did the aorto by fem, but only if the stenosis was in a certain position, because they couldn't do it for any distal disease. They did a bit of a TURPs, but I worked with a surgeon who could only do the right side of the prostate. He wasn't very good at the left. Carpal tunnels, if that... and certainly some general surgeons are still doing carpal tunnels now, but other orthopedic operations. And of course the upper GI and colorectal and all trauma. And often it was head to toe, so operating on head injuries, neck injuries, the whole lot. Around this time, our vascular colleagues started to look at what was happening and realized that something better could be done for their patients. At that time, and even now, the mortality from AAA rupture was extremely high. And as early as in the 1970s, super subspecialization was discussed. But it wasn't until the mid-2000s that it was separated as a widespread specialty. But what they noted was that there was a 4% improvement in survival in ruptured AAAs with those surgeons who did high volumes. So it wasn't actually necessarily the vascular surgeon, it was a surgeon who did a lot of those operations. I'd like to say that again that WA was ahead of everybody else, and we had our own vascular subspecialty team as early as the 1980s. Colorectal have done it. We've separated off as a subspecialty, certainly for the elective procedures. There was a lot of evidence showing that if a rectal cancer was operated on by a specially trained surgeon, then the local recurrence rates from that rectal cancer have been extremely low. So in elective surgery, people are obviously subspecializing. So who does emergency surgery at the moment? Well, at most hospitals, it's the on-call surgeon. And if we're completely honest, that on-call surgeon is on-call in the true sense of the word. They're actually doing something else. Most on-call surgeons, certainly in the public sector, are doing their public elective list, and certainly their registrars with them doing their public elective assisting, and they are from a variety of specialties. In the smaller hospitals, you have your upper GI surgeon, your colorectal surgeon, your endocrine surgeon, and your breast surgeon, all taking their on-call rotation. However, some hospitals, and again I talk about WA and our hospital in particular, have set up these acute surgical units. And the benefit of this is you have a dedicated emergency surgeon who can provide, as Professor Mountain was talking about, access to the emergency department and then the ability to take the patient to theatre in a timely fashion. And I suppose the question is, what should the training for these acute surgeons be? So Neela started on the back of, I think, of this paper that was published in 2013, which looked at what was happening in emergency surgery. And as we've heard over and over, the mortality from from patients requiring emergency surgery is far higher than that requiring elective surgery. The majority of the operations are, in fact, small colorectal or small bowel operations, and abdominal sepsis makes up a huge component of the problems that are presented, that these patients present with. So abdominal surgery is a major part of the emergency surgeon's workload. However, this paper did exclude gallbladder disease, and I think all of us who work in emergency surgery, and me particularly as a colorectal surgeon, a difficult gallbladder for me will keep me awake at night far longer than a laparotomy for a bowel perforation. So I'm going to present a little bit of our data to show how specialising or using specialist surgeons in the emergency surgery can change practice. So we did a retrospective review looking at all left-sided colorectal emergencies. These were obstructed cancers, perforated diverticulitis, volvulus, and a few foreign bodies. And what we did was compared the general surgeons with the colorectal surgeons looking at the outcomes. And we found, slightly contentiously, I think, for the whole of Australia, that our practice with the colorectal surgeons changed the management of patients quite dramatically. So when a colorectal surgeon was involved in the decision-making and treatment of patients with a left-sided colonic disease, 85% of these patients got a primary anastomosis, compared to just over a quarter of the general surgeons. And there were far fewer stomas performed at that time as well. The length of stay of both these groups were the same. The anastomotic leak rate was slightly higher than we would like for our elective cases, but remember, these are extremely sick patients at presentation, and not bad at under 10%. And our mortality was the same in the two groups. So what we found was having a specialist colorectal surgeon involved in the operation reduced the rate of stoma, was safe despite the dogma that all of us have, that anybody who presents with left-sided colonic pathology should have a Hartmann's procedure, but it did require, or does require, significant expertise and experience in deciding which patients should have the primary anastomosis and which shouldn't. And I'm grateful to James via the Independent Hospital Pricing Authority to give me this slide, but it shows that WA is performing way better than the rest of Australia in providing patients with a primary anastomosis. And it is thanks to the same surgeon who James mentioned at the beginning of the talk in Scotland, who changed the mortality and anastomosis rate for his patients in Scotland, who came and worked with us. And as a result, our hospital, as an individual hospital, has a far higher rate of left-sided anastomosis than other hospitals in WA. But you don't just need the colorectal surgeons involved with the operation, you need a whole package. And we've been talking about packages of care all evening. You need, I feel, an acute surgical unit. No longer can we really safely have the surgeon who's doing something else in another theatre who pops down and says, yeah, this patient needs an operation today, but I'm busy doing my elective case, I'll come when I can. And so I think in those hospitals where it's feasible, we should be having acute dedicated surgical units. These provide dedicated emergency beds and theatre for early availability of theatre, but also there's also an early consultant review. And in the very early days when we opened our acute surgical unit, we audited our results and found that there was a definite benefit to having an availability of a senior surgeon in reduction of bed stays, time from referral to review, and the fact that most of these patients were now having daytime operating rather than nighttime operating. So what should we have for this emergency service, or for who should be doing the emergency laparotomy, which was the question. And this is where I might be slightly contentious, but I think actually what we need is an emergency subspecialisation. We have elective colorectal surgeons, we have upper GI surgeons. Why shouldn't we have dedicated emergency surgeons who are providing work for about a quarter of what comes through, or a quarter or more of actually what comes through the hospital? Now, these surgeons do need to be colorectally trained. The majority of work that comes through the acute surgical unit is colorectal, but a high proportion is also upper GI and hepatobiliary. If you use your elective surgeon for your emergency surgery, and you provide the kind of care that we're actually asking for, so immediate senior consultant review, then you would have, you reduce your elective availability. So there is a compromise if you use your colorectal surgeons, for example, to provide all your emergency care. So I think an ASU surgeon should be a specialist emergency surgeon. I think they should have knowledge of trauma, acute colorectal and acute upper GI, and acute hepatobiliary. So what would that involve? I suspect that it needs to be a subspecialty, as all our specializations are becoming, with post-fellowship training, possibly in all of these three areas. Thank you.